Thank you very much, and thank you to everyone who's joined us this afternoon for our session on the Integrated Primary and Acute Care Systems, or PACS as an overview for today. We've got a great panel of speakers with us today. It's my pleasure, Mike Hannay, Managing Director for the East Midlands Academic Health Science Network, to be chairing today. I've got with me today Jacob West, who's the National Lead for PACS in the New Care Models organisation within NHS England. And Jacob's going to give us a quick overview of the PACS programme once I've finished my very short introduction. We're also very fortunate to be joined by Steve Stubbings, who's the Deputy Leader of the Isle of Wight Council. Steve's joining us by phone, and it'll be really good to get input from the Council programme perspective. And finally, we've got Marcus Pratt, who's the Associate Chief Finance Officer for Mansfield and Ashfield Ccg. We're also hoping that Jane Chisley-Clark and Jack Sharp will be joining us later on. So those are the panellists that we have today. We're also very fortunate to have with us some chat room and Twitter monitors. So we've got Charlotte Williams, and we've also got Dominic Kushnan, who's going to be helping us with the chat room and Twitter monitors. And importantly, we've got Paul Woodley, who's our technical operator and who is making sure that I don't make a complete mess of this afternoon. So that's the panellists, those are the facilitators, and what we really hope you'll do today is to join in, not just today, but also beyond. There's a great opportunity for people to ask questions of the panel through the chat box. Please feel free to connect with people, ask questions through the chat box all the way through the programme. We'll be picking those questions up and putting them to the panellists as they come through. We'd also love it if you could tweet what's going on today using the hashtag FutureNHS, which is lovely. And another way to ask questions is, if you'd like to ask a question verbally, then please put a virtual hand up and we will get to you and enable you to answer the question. We'll unmute you and let you go through there. At the end of the programme, our plan is to produce a Storify summary and make that available together with a recording of today's WebEx. What we'd also like to do, just to get an assessment of how much people know, how much people have understood about the PACS programme as they joined the call today, is to just get a bit of an interactive session to find out how much you know about the Primary Acute Care Vanguards. I'm going to hand over to Paul Woodley now just to explain how you can enter the information. Paul.
Good afternoon to everybody and welcome to today's session. The question we're asking at the moment is how much do you feel you know about Integrated Primary Acute Vanguards? Because we're hoping by the end of this session people will feel they've learnt and know a lot more about it. So could we get a poll of whereabouts everybody is at the moment? And to do this, we've enabled annotation for each of you. To use the controls, if you click on the top left of your screen where there is a pen symbol, just underneath where it says Quick Start, you'll get a list of options, and then you can make a mark to indicate whereabouts your current understanding is. So I can see people are starting to get hold of that. If you're struggling to get the annotation tools to work, if you're on an iPad, you can indicate through the chat box what your level of understanding currently is. Okay, Mike, I think that gives us a bit of a guide for who's with us.
No, that's great. Thanks very much for that, Paul. That's really useful to understand where we are in terms of our understanding for the Primary Acute Care Vanguard. It's great that we've got someone who's also got a 10 on the SCORE programme, so that's fantastic. Hopefully that's one of our presenters. That's really great. So hopefully by the end of today, people will have learned a little bit more about what's happening in the primary acute care vanguards. So for our next question, we'd also like to learn a little bit more about where people have come from today. And again, I'll hand over to Paul to take you through the process for annotating these.
Okay then, the process works exactly the same with this, and this is to give us an idea of who you are and where you're from. So if you use the same annotation tools from the top left of the screen, you can just let us know whereabouts you're joining us from. And again, if anyone can't use the annotation tools, or you'd like to expand upon it maybe and tell us a bit more about who you are and where you're from, feel free to put that information into the chat. We seem to have quite a nice range of participants with us today then.
That's fantastic. Thanks very much for that. Really is a good range of participants on the call today. So that's great. For the next session, it's my very great pleasure to now hand over to Jacob West, who's the PACS, the national lead for PACS within the new care models for the NHS. So, Jacob, over to you. Hi, Jacob, are you on mute?
Hi, Jacob. You're not muted on the system. Have you got a local mute?
Is that better?
That's it. We can hear you perfectly now.
Apologies, I had mute on my phone. Great that you can hear me, and delighted to be with you this afternoon. And thank you, Mike, for the introduction. So I'm just going to give a very few minutes of context setting, I guess, for people who are less familiar with the primary acute care system, Vanguards, and what we're trying to do with the wider program, and then hopefully give a large chunk of time for conversation with the other panelists and with all of the participants. So you have in front of you a map of England, which you should recognise, and this just puts in context the quite broad geographical distribution of where our 9 vanguards are. We've got 3 on the call today from Salford, from Isle of Wight and from Mid-Notts, but actually the distribution goes right up to Northumberland in the north. And these sites were selected, as with the other care models, in March 2015. So they've been going about 18 months. Some of them had pre-existing programs with similar goals. Some of them, though, were starting completely from scratch. And that might be one of the dynamics we explore today. How long does it actually take to deliver sort of large-scale change of this kind? So that puts PACS in geographical context. So what is a primary acute care system? And we never find great names for these things, do we? But let me try and put a bit of flesh on the bone. So at its core, this is about a population-based accountable care model. So what does that mean? Breaking that down into the 2 parts. So this is about a group of providers within a local area being focused on population health rather than just focused on how they are organised as providers. And we expect that to include primary care. Absolutely, this has to be based on the GP registered list. Also community, mental health, acute and social care services at the core. So this is a whole system model. Although the name might suggest it's just about primary acute care services, this really is about all of the breadth of providers in a local health and care economy. And so it's focused on population health, not just around provider interests, and it's also accountable for population health. That's the ultimate goal, so that providers collectively are focused on the full health and well-being of their local population through a shared set of goals and incentives, not just individual organizational incentives. So that's the top line definition. Actually, over the last 18 months, we've come to realize, I think, that the differences between PACS and MCPs are minimal. They may vanish into very little altogether. The couple of differences we do observe are, firstly, one of scope and one of scale. So PACS have the potential to integrate all hospital services into their local care model, whereas MCPs may bring in some hospital services, but we think they probably won't bring in the majority of them. But happy to have that comment challenged as we go through the discussion. And then there's one of scale. So the PACS potentially could be bigger, but I don't think that's necessarily the case. So currently, the Vanguards, the 9 that I talked about, have about a population of about 250,000, 250,000. In some instances, so places like Frimley Health, which is built around the Vanguard in North East Hants, we think they might scale up to the whole SDP. Somerset have got similar plans as well. So they're potentially very big in some instances, but I don't think that's sort of in principle distinction between themselves and an MCP. And the final point I wanted to mention was that this is a provider-led model. That is right. So these will need to be contracted for by commissioners, but it does redefine the responsibility somewhat between the commissioner and the provider. Things like population health management and managing multiple subcontracts. So these are responsibilities or activities rather that are likely to shift to some extent towards these new PACS entities as they come into being. So that's a very brief overview. The third slide, and there's only 3, you'll be happy to hear, I wanted to speak to is some of the specifics of the care model. So we published a framework that hopefully some of you have read in September of this year, a couple of months after the MCP framework, and it described 2 things really. One was, how will care change in a PACS system? And secondly, how does the underlying business model change? By which I mean, how do payment systems, contracting systems, and governance systems change? This slide just focuses on, this pyramid in front of you just focuses on the care model, but it's a fundamental principle of the program, I guess, that you need to change the business model, not just care pathways. So I'm not going to speak through all of this in detail, but for those of you who are familiar with the MCP model, and we had a session a few weeks ago that gave you an overview on that, you'll see that this is a near identical framework, reflecting the fact that the care models in terms of how care is actually delivered will be very similar, if not identical. It's just how you organize local systems around that may differ. So none of these individual elements that are about population health are in themselves novel. I suppose the radical thing, if you like, the different thing is being able to systematically implement these in a local area, underpinned by a new way of doing business. So I'll pick out just a few specifics to try and bring it to life. So in the whole population segment, which is the bottom tier, this really emphasizes the fact that these systems, these PACS, are not about just about care delivery. This is actually about upstream focus on preventative health. So, for example, we talk about their better population health through community engagement. Morecambe Bay, I think, is a shining example of this, what they've done in the Milham community to re-engage a whole population to think very differently about its healthcare. I think Isle of Wight, and Steve may talk about this in a few minutes, have got some really fascinating ways of working with their voluntary and community services to try and recast, if you like, the relationship between patients and the public and healthcare more generally. Self-care is a big part of that as well. North East Hants, for example, using a service called Making Connections, which is about supporting people to look after themselves in the community. Moving up a tier then to urgent care needs. This is about an integrated approach to unplanned and emergency care. Just a couple of examples here. Again, in the Isle of Wight, they have a fantastic integrated hub which brings together social care, 111, out-of-hours services, community services, with a single call line to try and join up that service for the 140,000 or so people on the island. It's also about getting the services organised around that. In Mid-Nottinghamshire, Marcus, who's on the call today, may speak to this. They've got something called Call for Care. That's a single line for paramedics or GPs who've got a patient who might be in a subacute condition, thinking about what's the right package of community services to keep them out of hospital, to keep them at home ideally. They call up a single number, they'll get a very quick response with someone who's expert in community services and will help organise around them. Last two areas then, ongoing care need. This reflects, I suppose, the changing epidemiology. More and more people have got multiple health conditions, particularly those who are living longer. That's a great thing, at least that they're living longer, but it means for health and care systems, we need to organise ourselves differently. This isn't about one intervention, this is about multidisciplinary input, I guess, at its core, through scaled up, enhanced primary and community care teams. A couple of things I might mention there. Somerset are making fantastic use of health coaches in almost all of their GP practices to try and have holistic assessments of people's full health and well-being needs. Places like Harrogate and Mid-Notts have rolled out MDTs involving mental health practitioners as well as social care practitioners, occupational therapists, GPs and other primary care professionals to try and have real-time conversations about patients with the most complex needs and again, in a preventative fashion, implement new ways of working for them. And then finally, in terms of the highest, those patients with the most complex needs, we are trying out different ways of working. Sometimes we call this the extensivist model, which I suppose South Somerset are our best example of, but many of the MCPs, places like Fylde Coast and others have got versions of this as well. This might mean a physician following a patient right through their community and their inpatient healthcare needs. In Somerset, it means we've got complex care hubs up and running. It means greater, it means greater in-reach into, I've just lost the slide, into the hospital from healthcare professionals. GPs are walking the wards, for example, at Frimley Health in ways they haven't done for many decades, people tell me there. So that is just a very brief overview of some of the richness of the different elements of the care model. I'm going to pause there and I hope we pick up some of those specifics, but also some of the broader principles in the conversation. Mike, have I kept the time?
That's fantastic. Thanks very much, Jacob, for that really good and thorough run-through in a really short period of time. That was great. So it's now my pleasure to ask some of the panellists to maybe build on Jacob's picture and talk about their experiences with working within the PACS framework. So perhaps I could go first to Steve Stubbings, who's on the phone from the Isle of Wight.
Certainly, thank you very much, and thank you, Jacob, for that very interesting and helpful introduction to what's going on in some of the PACSs thus far. Jacob's already told you we have a population of approximately 140,000. We start with a significant advantage of having one local authority, which is a unitary authority, one NHS trust, and one CCG. So, frankly, I think it's been, with some justification, suggested that if anyone can do integration, the Isle of Wight can. We had already started on a journey with a project called My Life a Full Life before Vanguards came along. So we had a head start in terms of building the important relationships between the sectors which are vital to moving something like this forward. You've got fairly monolithic established organizations with certain ways of working that are fairly ingrained, and the kind of culture changes that you're looking to try and deliver within a model like this, it require a great deal of mature and sophisticated relationship sharing. I think it's important to say, do not underestimate how much work's going to need to be done in terms of developing trust amongst the senior key players that are going to be decision makers in terms of how we move forward here. We had already made some progress, and our aspiration is a really big one. Our aspiration is for £1 island. We are looking at the possibility, if it's possible at all, to establish a place where there is a single pot for health and social care spend. And I recognise that's radical and will probably sound unlikely to some, but we believe that that could be possible, and we also believe that if we were able to deliver something around that, it would improve outcomes for those people that use our services. In addition to that, of course, there is also a potential for finding significant economies in terms of how we operate around that model. Some of the progress that we've made, Jacob has already told you about, and clearly we are trying to push forward that fundamental integration between the work that the CCG do and that the local authority does. And I have been involved as a lead counsellor in this project pretty much from the beginning. And the one thing that I really regret is that almost every meeting I attend on a national level, I appear to be the only elected member there. And I find that quite distressing, actually, because what we need to recognise is that we have to have political buy-in on a regional basis for a lot of what we're hoping to do. So it is actually quite important that we get engaged with our elected members, because in the end, they're the ones that are most likely to persuade the public of the importance and of the value of the kind of changes that we're looking to make. So I've had the privilege of being involved in this project almost since its inception. I was one of the team that came and presented to New Care Models around the Isle of Wight's model, and I've met with Jacob and Sam and others involved in the project on a regular basis. I attend the extremely valuable King's Fund events around how we can share information between each of the models. I was with Salford and with Northumberland, and I don't know if Notts actually got there on Monday, but we were at the King's Fund then, sharing experiences and some of the developments in our own areas. And I think that's been of tremendous value to be able to glean information from one another's experiences rather than each of us reinventing the wheel on a regular basis. I hope that helps as an initial introduction. And you will understand that my perspective comes from a local authority perspective, with a recognition of the fact that health and social care are inextricably linked, and when one fails, the other fails, and vice versa. And I suspect that the government is finally actually beginning to understand this fact.
That's great. Thanks very much, Steve. And I love the concept of the one island pound. That's really good. And now moving from the beautifully, perfectly formed and from what Steve says, integrated Isle of Wight, we can now go to the equally beautifully Mansfield and Ashfield Ccg to get Marcus's thoughts on the PACS programme.
Thanks, Mike. And our experiences are relatively similar to what Steve was talking about there. We are PACS Vanguard, population of 320,000 in Mid-Notts. Mid-Notts comprises of 2 CCGs across Mansfield and Ashfield and Newark and Sherwood. Mansfield has some of the most deprived urban areas in the country. Then we've got a very rural population and some of the most affluent areas of the country across on the Newark side as well. We again have been looking at integration for longer than the PACS programme has been in place, probably for the last, getting on for 4 years now, 3.5 years. We've been looking at integration across our services. We started looking by asking the population and clinicians what do services look like in Mid-Notts, and we got similar answers to what was being populated in the 5-year forward view at the time, around fragmented services, very hard to traverse sectors. We also did the same piece of work we've done the STP recently, looking at our finances as a whole system, and saw that on the current trajectory, if we don't do anything about it, we're going to see tens of millions of a financial gap, which is certainly coming to bear, other than the mitigations that we've been able to put in place to start to reverse that. So what we did was look at, well, what can we do about it? And I just want to talk briefly at this stage around 3 different areas. One is around the care model, secondly around our organisational form, and then thirdly around incentives. So the care model, and Jacob touched on some of the stuff that we're doing locally, but we are basically putting in place a number of services that will improve demand management or certainly reduce demand, both in terms of urgent and proactive care and also in planned care services. We have created NDTs, multidisciplinary teams, including social care, including mental health, including allied health professionals, and the third sector as well. And we're also looking at now services both at the front door and the back door of the hospital. So how do we stop people getting in if they do come to the front door? Our ideal is to stop them getting to the front door in the first place. So if they do not need to be at the front door, where else can they go? And also at the back door, how do we ensure that those people who are ready to be discharged are discharged in a timely manner? And I can talk a bit more about that later on as well. In terms of our organisational form, we have an alliance in place, and we have a formal alliance contract. That's come in place over the last year or so. The alliance partners are many and include 3 acute trusts. We have 3 acute trusts who serve our population, a single trust who deliver mental health and community services, the 2 CCGs, the local authority, both as a commissioner and a provider, out-of-hours services provided by a social care enterprise, an independent provider who provide services to the south of our county, and TEAM, who are an umbrella organisation who overlook our third sector. The one element that we do need as part of that alliance, but haven't yet come to the table as a single body to represent that, are primary care. They do sit around the table, and they are vital that they are around the table, but we're just talking to them about how do we make sure that they are a decision-making partner as part of the alliance. The alliance itself has a leadership board and then a governance structure which makes decisions about how care is planned and strategically planned across the whole of mid-Nottinghamshire. And the advantage of having an alliance is something you can do very quickly. So without needing to go, we maintain the bilateral contracts between commission and providers, contracts for services basically, but it is a way of ensuring that all parties are together around the table speaking with one voice about what is best for mid-Nottinghamshire and the people of mid-Nottinghamshire. We are potentially on a journey here. We haven't precluded the fact that at some point we may need to go to procurement, but there are a number of tests for the alliance. Can we make decisions quickly, being one in particular? Do our individual organisational forms prevent us from making a single decision for the best for our population? And then finally, payment mechanisms. One thing that very much is aligned to the alliance is we need to ensure we have the right incentives in place. We know that we all respond very much to financial incentives within the NHS and within the local authorities as well in social care. So we are making sure that at the moment PBR does a job. It reimburses the acute trusts for at least some of the increased cost of increasing activity, but does it give everyone the same incentive to drive down cost in the system, and in our case, to move costs and activity out of the hospital and into the community sector? It probably doesn't. So we are designing a whole population budget with a risk and reward share that we all, as a system, will share any gains and any risks across that system. We are just starting to crystallise that now in terms of putting in place an MSK service, musculoskeletal service, with a shared whole population budget and shared risk and gain across that, with a view that that will be in place from the 1st of April. Mike, I'll pause there. I won't go into loads more detail about it, but we can pick those elements up further as we go through.
That was brilliant. Thanks very much, Mark. And that was a really informative overview of what's happening with the mid-Not. I believe we've now got Jack Sharp as well online. So, Jack, it'd be great to hear your perspectives.
Okay. Hi, can you hear me?
Yeah, that's lovely. Thank you.
Excellent. So yeah, hi folks. I'm Jack. I'm Director of Strategy at Salford Royal Foundation Trust, and I'm kind of here on behalf of Salford Together, which is our PACS, and lots of consistency with things you've heard from Jacob and others. So I'll give you a bit of a whistle-stop tour of the Salford kind of integrated care system and what we've been doing. So we have a population of 220,000 just north of Manchester, quite a deprived area, though lots of strength, lots of assets. I guess one of our strengths has been a history of partnership working and a history of collaborative intent to address the problems or challenges that often face the city or indeed individual organisations. And we've kind of grasped this notion of the Salford pound, the idea that every investment or disinvestment decision in Salford actually needs to be targeted at the Salford population, and each decision is an opportunity taken or gained for the system as an entirety. We have a relatively coterminous population, single CCG, single local authority, single foundation trust that now, as of July the 1st, is an integrated care organisation delivering acute community health services and having responsibility for delivering or contracting adult social care and mental health services. And I'll come back to that in a moment. But we have 4 statutory bodies that have been working together closely, the CCG, the local authority, my organisation and the Mental Health Trust. And as of the 1st of October this year, a single GP provider body called Salford Primary Care Together. We've been working together specifically on this journey for probably 3 years, so it predates our PACS status, and as is, I guess, often the case, sort of success and positive progress kind of can help reinforce changes you want to make. A pretty simple triple aim, again, we're quite happy to steal ideas from anyone else. So we've taken the IHI triple aim of delivering better outcomes, better experience and reduced cost through transformed and integrated care for the population. Very much focusing on how we deliver person-based, person-based care, but focused on the entire needs of the population. We talk in Salford about Sally Ford and the Ford family, so that's kind of our version of Mrs. Smith. Lots of things, lots of ingredients, and Jacob's gone through the kind of PACS framework that make up our journey. But I guess I'll focus on 3 things: the model of care, governance, and enablers of change. So we've built a model of care, I guess, partly bottom up through deep staff engagement, partly through looking at the evidence base, and I say partly from being very happy to steal and borrow ideas from others. And nothing, I think, in our model of care is unique, but I guess our successes so far on our journey are about how you glue the parts together. So community-based multidisciplinary groups bringing together GPs, district nurses, social workers, mental health practitioners, colleagues from the community and voluntary sector, supporting case finding, risk stratification and case management, very much delivered on a neighbourhood basis. So neighbourhood focus is a core element of our model of care, and I guess is in some ways akin to the MCP model. Centre of contact, offering a single point of access, care navigation and support. And a significant focus on community assets, supporting individuals to be connected to volunteering, to community groups, supporting social connections and preventing social isolation. those three kind of core components, I guess, have provided a platform from which we've built lots of other elements. So working with community housing providers, working particularly at the moment with care homes, re-engineering aspects of the intermediate care and domiciliary care system. And I guess part of that has been organic and part of it has been structured. In terms of governance, we've been on a journey. So we initially developed sort of partnership arrangements to support redesign and collective decision making. About 18 months ago, that morphed into or formally moved into an alliance agreement, so a formal mechanism to bind commissioners and providers together, supporting some risk share arrangements. And at the beginning of this financial year, that moved to the kind of current stage, which was more formal governance through integrated commissioning, so the establishment of a pooled budget and joint commissioning arrangements for the full adult population between the CCG and the council, so elected members and GPs, establishing shared governance arrangements, and the formation through a prime provider model of our ICO, bringing into one organisation responsibility for the delivery or subcontracting of the vast majority of health and social care services for the adult population. The third element I wanted to just kind of touch on, I guess, were probably the enablers for change, and just highlight four things that have been important and helpful for us. One part has been a focus on how we actually co-design and transform care, and we've used very much using improvement methods, used sort of improvement collaboratives, PDSAs, and deep staff, public and partner engagement. As we brought services together, we focused very much on kind of cultural and behavioural change, and brought in external support to identify and recognise some of the obstacles that can get in the way. We've also built upon something we've had in Salford for a while, which is the Salford integrated record, to create a single shared record for the adult population. And lastly, creating the mechanisms through which we can share and manage financial risk, for which we are on a journey from pooling of budgets and formally sharing risks between commissioners and providers to ultimately moving towards a capitation model. All of that really hinges upon a very clear and firm shared collective endeavour. So the alignment of values, behaviours and a common vision really acts as the glue from which everything else flows. So I'll kind of pause there, happy to pick up issues as part of the conversation.
That's fantastic, Jack. Thanks for sharing the experiences in Salford. I think there's some very rich material coming through. I believe we've got Jane Chidgey-Clark on the line now as well, and I wonder, Jane, if you'd like to share your thoughts on being involved with the PACS framework. No. Okay. Whilst we're waiting for Jane, we'll take some questions from the that have come through on the panel. I'm just looking through the chat box, which has been some really interesting discussions on there. And I think one that's come up, which is there a clash in meeting the needs of those with the most complex needs at the top of the pyramid and those with urgent care needs? And do the urgent needs override the important needs? Always a challenge in this environment. Perhaps if I could start, Jacob, if you'd like to start off with that one.
Yeah, thanks. Thanks, Mike. Can you hear me?
Yeah, that's great. Thank you.
Yeah. So I started to write it down in response to Helen's question. I think, in a way, that's not a new tension or clash created by these systems. In a way, it's one of the fundamental reasons that we're trying to create models like PACS and MCPs to address that, because I observe that, and I spent a few years working in an acute trust as one of the problems with the current system, that actually we haven't created enough headspace, enough room to be able to optimally look after people who might have a number of long-term conditions. You know, the 7-minute GP appointment, just because GPs are having to see 30, 40 people a day, doesn't create time and room to be able to do them full justice. So if you can start to create a system that manages demand better overall, then I think you create a bit of space, a bit of resource to be able to, in parallel, find different ways and better ways of looking after those patients, those service users who've got the most complexity.
That's great, thanks, Jacob. Does anyone else from the panel, want to add to Jacob's response?
Sure, Marcus here. Sorry, so yeah, just to build on that really, there's something about, at the moment, creating services both to manage those people with those complex needs and having those bespoke services, but also the whole Choose Well campaign, I think, is really important, because at the moment the people who are rocking up to the front door don't necessarily need to be there. So if we can get those, both the services in place and the message in place, that often those people who have those urgent needs could be urgently seen in a different setting, I think that would help. But a lot of it is about just creating space and headroom that people are seen and treated appropriately within the right setting.
That's great. Thanks, Marcus. Did I hear Steve wanting to jump in?
No, you didn't actually, but I will jump in on the basis of what Marcus has just said. I think something that's quite crucial in the conversation, which we're all having, and really encouraged to hear Jack from Salford speaking about something that pretty much mirrors exactly what we're doing. So, Jack, we need to get together and have a chat and see if we can share some experiences. In terms of our new care model, there is an absolute imperative for us to shift the concentration of the money that we spend and the energy that we exert into prevention and early intervention, because you then stop people from escalating to the point where they require those more acute services, and eventually the whole system will see benefits from that. So we're genuinely concentrating on shifting resources to a place where, with a new kind of pathway into the system, that means that we can, as best we're able, alleviate the problem at a very, very early stage. So we're spending a lot of resources on things like local area coordinators that are addressing some of the issues around loneliness and isolation. Mental health problems obviously have a massive impact on where people go after their initial kind of connection with mental health services. So there's a lot to be discovered and investigated around how we move things to a place where we stop the big problems from actually escalating to the point where they end up costing us a huge amount, and where there's no benefit at all to the people for whom we are providing services.
That's a really good point, Steve. Jack, I wonder if you wanted to come in on the theme of prevention and stopping people getting through the door, as Marcus put it.
Yeah, I think one of the interesting debates we had right at the outset of our integrated care program in Salford was, I suppose, a philosophical debate about should we be focusing at the top or the bottom of the pyramid, and it was really driven by, I suppose, a recognition when we got into the conversation that actually we needed to do both. That you have to deal with today's problem, that people are presenting at A&E and often being admitted to care homes and are and are often consuming, not due to their fault, but due to the faults of the system, a disproportionate level of health and social care resources, because the system's perfectly designed to create that. And you have to do that, you have to focus on that area, because if you can re-engineer some of it, you can both relieve pressure on the system, but also release costs to create a more virtuous cycle by focusing then upstream in prevention and community-based resources, care and support. But you can't just focus on one end. You have to simultaneously focus efforts on how you support people and prevent people becoming ill in the first place, or how you address the early onset of disease or comorbidity. And I think as a system, if people have bought into the concept of, the Salford pound, the Leeds pound, the whatever, that becomes really a debate about the quickest way to maximise the gains for the population, rather than a debate about should we be investing in my organisation or your organisation. Because if people have committed to that concept, then you can find ways in which you mitigate some of the problems along the way. So I think we quite early decided that we had to focus both on putting the fires out and preventing the fires occurring in the first place.
Thanks, Jack. I think that's a really valuable point. And a lot of the points that the panellists have echoed, I think, are points that we would see in the STPs that are starting to be published now. And I have a couple of questions from Anna and Dominic around, do the panel think it's possible to form PACS in the timescales the STPs are working to, particularly where collaborative working is less well established? I wonder if we could start off with Steve this time.
A really quick answer to Anna, no, I don't. I'm really sorry to be so blatant about it. I already alluded to the fact that it took us a long time to develop the relationships that meant we could have meaningful and robust dialogue when problems come along. And I fear that the timescales around STPs are way too tight for that to be possible.
Thanks, Steve. That was very clear. Any other viewpoints? Marcus, would you echo that?
Yeah, probably I would. I think can't underestimate how key relationships are in this. If at a senior level, if you don't have your chief execs, your finance directors, your clinical directors talking the same language and aiming at the same goal, you're really going to struggle. So I think, first of all, that's the place to start. So if you don't have good relationships and not collaborative working, building those relationships is key. But then following that is kind of then getting that culture right across the system, because that's the starting point. But then changing the culture in the organisation when people have been used to the old contracting round where we are now butting heads, old contracting speak, then we'll struggle. Just slight aside, our regulatory framework doesn't help in all of this either. So when we're in a regulatory framework where we are looking at you must meet your individual organisational targets, particularly your financial targets, rather than system-wide targets, and we are moving towards that, which is great, but that doesn't help with people being able to build those relationships. So yes, the timescales are incredibly challenging, but we have been set that challenge, so let's think of how we can conquer that. I would suggest the first place start is build those relationships and change the culture.
Oh, that's great.
Mike, sorry Mike, it's Jacob, could I add a quick word on the back of that?
Absolutely.
So I think I'd agree with both Steve and Marcus. I think you can't rush the relationships either. What I would add to that though is STPs are quite big, and change sometimes happens on a bit of a smaller level. Most of the Vanguards, if not all of them, are smaller than STPs, even if some of them have ambitions to grow to full STP size. So, and even within the Vanguards, I think colleagues would agree that there'll be variable development. Some neighbourhood teams will grow quicker than others, and actually creating a sense of a comparison, even a bit of competition between those teams, those groupings, can be one way in which you build from quite a small scale up. So I don't think you need to have the relationships right across the whole system to get going. So that would perhaps be a positive sort of footnote to the point that Steve and Marcus made, which is absolutely focus on relationships first.
I think that's great, and I think one of the other questions that's come on builds on that, which is being one of the PACS Vanguards helping sites to accelerate the removal of barriers and disincentives within the system. Jack, would you like to comment on that?
Yeah, I suppose we started from a position of strength, so we haven't required sort of PACS as a way to sort of bang heads together. We started from a position of strength as in positive relationships. I think what it gives us is a focus. It gives us a sense not only of an intrinsic internal purpose and a framework within which we can sometimes bounce ideas with other sites. We have that external challenge and kind of constructive sort of push for us to try and do more. But I don't think, and I guess, you know, I was reflecting on one of the issues we experienced maybe about a year ago when we were having some challenges with not one of our statutory partners, but one of the others. I think we had an external view, and that was really helpful to, I suppose, assess whether as a system we were responding to that challenge in the right way. And apologies, I'm being slightly opaque because I don't want to name the entity. There have been times where, as a system, we've used external facilitators or external thought leaders to help mobilise sort of pace in decision making or to coalesce thinking. So I think you can use external interventions. You don't have to be a member of a new care models kind of a pilot or site to do that. There are other ways in which you can do it. But the bottom line is partners need to want to move forward in a constructive way together to kind of connect it back to the previous topic of conversation. There needs to be at least a coalition of the willing from which you can then build.
That's great. Coalition of the willing is a key factor. Steve, have you found a similar thing in the Isle of Wight, or has it been easier with you being abused?
Who have already been on the journey. I don't think we would be where we are, as far advanced as we are, unless we had already, as I said earlier, established those strong relationships that carry you through difficult times. But I would throw something in here which I think is really important, particularly in relation to the STPs, and that is beware of there's a possibility that by trying to rush stuff through quite quickly, we don't take the full responsibility for public engagement and consultation. And I think in relation specifically to an issue like the STP, which will naturally engender a fair amount of emotive response, I think we need to be really, really careful about ensuring that we give the public an opportunity to hear what's proposed and to voice their concerns or their opinions about it. And I think that up to now, we have all, I think, as a system, struggled with getting to that very mature conversation with the public about the necessity for change. And whilst we all know it, all of those in the room and listening understand exactly about that, I don't think the public do yet, and I'm very concerned about the point at which we arrive at sometime in the not too distant future when suddenly they realise that what they have become used to is not going to be what's going to be on offer in the very near future. That concerns me quite a lot.
No, I think that's a really good point about the public engagement across the piece. Jacob, I wondered if you'd like to give a view on how the engagement's being managed across the Vanguards, the examples of good practice you've seen.
Well, I think where it's happening best, Mike, and maybe that Marcus, Jack, and others want to come in on this, is it's not seen as a sort of process that you do on occasion to tick a box to allow a change to happen. It's actually really trying to, it's easy to say, but really trying to recast the relationship between people and their local health and care systems. If you want to get that benefit in terms of people looking after themselves, communities looking after themselves, you have to have a really different way of doing it. The example, it's only a small community, but the example that I think has done that most dramatically is in Morecambe Bay, which is the Milham community. There's lots of material available online for this, and there's a King's Fund write-up of it for those who are interested in reading more. But just very briefly, this was a small town in rural part of Morecambe Bay that with the threat of a closure of a local cottage hospital, and with the District General Hospital furnace being over an hour away, it galvanised the local communities to think very differently about their own health and care, bring in a whole range of services, but they've just extended that to really changing the culture around dependency on health services in their community. So actually that happened organically. So one of the things we've been thinking about is how do you sort of bottle the spirit of Milham and build that and foster that in other places. I think some places, you know, many people say not everywhere's like that, but actually every community has its own energy and assets. You just need to find a way of tapping into it. So for me, it's not about consultation is the sort of the thin end of the wedge. The sort of thick end is really redefining the relationship with the public, making them feel like they're owners and stakeholders in their local public services.
That's brilliant. Thanks very much, Jack. And time has really flown by, and we're really right at the end of our programme now. So my thanks to all the panellists. Jacob, could you do me a favour and move us on to slide 12, as you still have the presenting key? There we go. Paul, we've just come to the end now, so what we'd like to pick up now is how much do you feel you now know about the integrated primary acute care Vanguards? So, oh, that's great. Paul, do you want to talk us through the process again?
Sorry, yes, I just had to give everyone the ability to annotate. If some of you have joined us midway through the session, this is just to find out what level of understanding you all feel you have about the PACS now. To make an annotation, there is a tool on the top left of the screen, just underneath Quick Start. Looks like a pen symbol. If you click on that, it will give you a list of icons, and you can then make a mark on the scale to let us know how much you feel you know now. And I can see, Mike, that people seem to have absorbed everything you've been talking about.
That's absolutely fantastic. A great move across, which is what we really wanted to see. So we are really now right on the edge of time. So can I take this opportunity to thank all the panellists for the great interaction, for the great answers to questions that we've had. That I think the poll at the end shows how really informative it's been for everyone involved. And thank you to Paul, who's been helping to make sure that this all works. So with that, thank you very much for your attention and have a great evening.
Cheers. Thanks very much.